In about 2 months, the nodule was reduced to half in volume, and in 6 months, percentage of reduction was about 80%.
Wow.
If the patient normal thyroid function, I have never seen a hypothyroidism afterwards. This is the difference between the radioactive iodine and the embolization. So in multinodular goiter, our first choice is embolization. It will treat all the nodules in one go, in one single procedure. This is another weapon in our arsenal. Ablation uses freezing. I like this treatment very much because it is very different from heat-based ablations like laser, radiofrequency, and microwave. They have a lot of advantages and still using them quite often. But cryoablation is another thing. I have tried this for about 7 years in over 100 patients. And maybe I'm too lucky, but I have never seen a recurrence.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Professor Saim Yilmaz, an interventional radiologist practicing in Istanbul and Antalya, Turkey. Throughout his 40-year medical career, Professor Yilmaz has worked exclusively in this unique specialty, treating patients with multiple image-guided, minimally invasive treatments. He is a pioneer of non-surgical thyroid treatments. In 2018, Professor Yilmaz founded Verisign Interventional Radiology Clinics, where he leads a team of 5 doctors and 19 staff. He speaks English, French, and German. In today's conversation, we will focus primarily on 2 non-surgical thyroid procedures for the treatment of thyroid nodules and cancers: cryoablation and embolization. Professor Yilmaz, welcome to the podcast.
Thank you. Hello, hi.
It's really nice to speak with you. I've heard a lot about you from patients in our community, particularly one patient, Kathy, who's been to see you for a couple of different procedures, and she's been a huge advocate for embolization. And so I'm just really excited to talk with you today and learn more about your practice in Turkey. As we get started today, why don't you tell the viewers a little bit about your practice and your background in medicine as you're an interventional radiologist, correct?
Yes, I am an interventional radiologist, and I also have a special interest in interventional oncology. Okay. So I like my profession, and I'm very happy to be in that field because it is exciting. It is very open to innovations. I am 62 years old now, and I have been a doctor for about 45 years. And I have spent about 40 years in radiology and almost 30 years in interventional radiology. So, I have worked in every part of interventional radiology in, for example, angioplasties to open peripheral vessels or doing neuro interventions like aneurysm embolization or AVM embolization. And then we started varicose vein treatments for the first time in Turkey. And nowadays I do more oncologic interventions, and thyroid interventions is an important part of it. Interventional radiology is an interesting branch because unlike other disciplines of medicine, you're not dealing with one sort of patient group. So you're not dealing with pediatrics, with kids, or women, or iron disease, or ENT, etc. So you deal with a lot of different patients. So I think this gives you some advantage of creativity because in one place or in one particular patient group, if you think that a treatment is good, then you can easily adapt it for another patient group or another procedure. So I always think what I can do for my patients in a better way or in a new way. This is my way of thinking. I started like any other doctor in the thyroid nodules, benign thyroid nodules, and I have done alcohol ablation, laser ablation, radiofrequency ablation, and then microwave ablation for benign nodules. And then I have seen that there are other problems in the thyroid.
Right.
For example, there are a lot of patients who has large thyroids. There are some patients that have substernal thyroids going into the chest cavity. Their problems are bigger because they definitely have to take surgery, and the surgery has certain advantages, disadvantages, and risks. So I thought what I can do for such people besides the ablation, because these people have benign disease and most have normal thyroid hormones and normal functioning thyroid. And we know that thyroid is a very important organ. So I just thought what I can do or what I can offer for such patients to treat them and also to preserve the thyroid based on my past experience in embolization in other organs, such as fibroid embolization. So I thought embolization may be a good idea because similar to fibroids, thyroid nodules are quite vascular. They have a lot of blood vessels. So we know that embolization may work in such pathologies, hypervascular pathologies. But it took me about 2 years to try this treatment in a patient because it is not possible to get one patient and try it at once. This particular patient was supposed to go to angiography, and we were supposed to do intraarterial chemotherapy for her breast cancer. And she also had a lump here, and on ultrasound it was vascular. She asked me whether I can also treat this thyroid nodule. And since it was very hypervascular, it was not very suitable to put a needle because there were a lot of blood vessels. So since she was supposed to undergo an angiography procedure anyway, so I told her that I can do this procedure also. And shortly after the intraarterial chemotherapy, I also embolized that particular nodule, and it was great. I mean, in about 2 months, the nodule was reduced to half in volume, and at 6 months, the percentage of reduction was about 80%.
Wow.
This is despite that I embolized only one artery. Later, I found out that I should have embolized more arteries. So this was called the first patient. And then I did this technique in other patients that were not suitable for surgery, but they have substernal goiters, and the procedure worked very well. Then I continued, and then we published an article about embolization in JVIR journal. After that, it drew a lot of attention, and I have had some guests from United States and Britain also, some doctors. Okay, this is one story, and another story is cryoablation.
So I want to talk about that too, because that's one area I need you to educate me on, because I do not know very much at all about cryoablation, but this is fascinating. Please continue.
It's been in use in medicine for about 30 years. And urologists actually were forced to deploy this treatment in prostate cancer and kidney cancer. So it's a well-known technique, in fact, but later the urologists gave it up, and interventional radiologists started cryoablation because it was possible to use very small needles. So we were able to use it more in the breast, for example, breast cancer, in thyroid cancer, in pancreatic cancer, lung cancer, liver cancer, in sarcomas, etc.
Wow.
Yeah, I like this treatment very much because it is the mechanism is totally different, and it is very different from heat-based ablations like laser, radio frequency, and microwave. As you know, we use all these things for malignant tumor ablation. I mean, to treat some cancers, like liver tumors or lung tumors. They have a lot of advantages, and I'm still using them quite often. But cryoablation is another thing. Cryoablation uses the freezing. Right. So it produces ice. And the very good thing is, during the procedure, you can see the ice on ultrasound and on CT. This is something we don't have with RFA and microwave. Because in RFA or microwave, you can never be sure which area are you ablating and which area are you preserving or avoiding. But you can see it clearly with cryoablation. So with cryoablation, since it is practically painless because it is not using heat, it is using ice. So as you know, ice has a natural local anesthetic effect. So it is, I thought it is very well fit for thyroid, because to do ablation in the thyroid, the patient needs to be awake, because you need to check the function of the nerve, recurrent laryngeal nerve. So you have to check the voice of the patient. For RF, microwave, or laser, you need to do a lot of local anesthetic around it. So sometimes the patient the patient's voice may become hoarse, and you can never know if it is due to the local anesthetic or the ablation itself. So it is, you know, because they are more painful, and they are more painful after the procedure also. But cryoablation is practically not painful. After the procedure, there is no pain at all. And you can see during the procedure, you can see what area you are freezing and what area you are avoiding. So I think it's, to me, I'm very happy that I started cryoablation in thyroid also. And this was because I had used cryoablation in other tumors for about 15 years. So based on my own experience, I decided to start this. So the basic disadvantage of cryoablation is its cost. Its cost is almost double or triple compared to RFA or microwave. So if the patient has a benign nodule, I'm still using RFA or laser or sometimes alcohol. But if the patient has a cancer, thyroid cryoablation is the right choice. This is my opinion, because you can make sure that you are killing the tumor completely, because you are seeing it all the time. I have tried this for about 7 years in over 100 patients. And maybe I'm too lucky, but I have never seen a recurrence. And I have treated very difficult tumors. I mean, not thyroid microcarcinomas, like thyroid cancers of 2 centimeters, 3 centimeters, even 4 centimeters. So it was very, very successful. So basically, in short, I'm still using laser and RFA in benign nodules. But if the biopsy result is a papillary cancer or follicular cancer, or it is suspicious for cancer, then I shift to cryoablation. So this is my practice in summary.
Thanks so much for watching this episode. I hope you're enjoying it. You know, this podcast requires a lot of my time, effort, and resources, but it is a labor of love. If you'd like to directly support my work here, you can do so in 2 different ways. You can purchase products from one of my affiliate brands, or if you would prefer to make a donation directly to the podcast, you can do that as well. Links to do either are located in the description below. Every dollar contributed goes right back into this podcast. Additionally, if you'd like to support the Save Your Thyroid patient advocacy community, which is working toward becoming a nonprofit organization, you can donate via our fiscal sponsor, THYCA, Thyroid Cancer Survivors Association. Simply visit thyca.org, click donate, and designate your gift for SYT. To learn more about us and the work we do, please visit saveyourthyroid.org. If you have any questions about any of this, don't hesitate to email me at saveyourthyroid@gmail.com. Any way you choose to support the podcast or the SYT community is sincerely appreciated. Your generous contribution keeps this work going and helps us to help more patients like me and you. Thank you so much for watching, and now back to the podcast. I just want to mention your website is incredibly helpful. As I was preparing for this podcast, I looked at your website, and I'm going to put the link for that in the description of this video for anyone who wants to look at your website. Having information on there about all of the procedures that you offer that you listed just a second ago. But one thing I wanted to ask you about, particularly about cryoablation, you mentioned that the critical structures are not harmed by the cold during the ablation. How is the cold able to kill the nodule itself but not harm the critical structures around it?
Okay, I don't want you to misunderstand me. Cryoablation or the eyes does harm the nerves, okay? But it doesn't harm, for example, trachea.
Okay.
It doesn't harm a lot to strap muscles.
Okay.
Okay. It doesn't harm to vessels, for example.
Okay.
Okay. Because the blood flowing in the vessels will protect the wall of the vessel from freezing. Okay. So this is a little bit different with microwave and RFA because heating a tissue is more aggressive than freezing a tissue. Okay. Consider the frozen animals. That died 1 million years ago. Okay. And when you look at them, they look the same. Okay. They are there. So cryoablation is more respectful to collagenous tissue. Collagen means, for example, bone, heart tissues, tendons, muscles, vessel walls, or if you're using it in the liver, for example, it's biliary tubes or biliary channels, or in urine channels, in the prostate, for example. Freezing and heating are different. So freezing in general causes less complications or less harm to surrounding structures, but not to nerves.
Okay.
Freezing will harm the nerves very easily. But the good thing is we are seeing the ablation area continuously, and we are checking the voice of the patient. So if the patient voice changes, we can stop immediately, and we can warm the ice ball, and we can melt it. So we can take measures as soon as it is necessary.
Very interesting. And my other question about cryoablation is the appearance on ultrasound. You mentioned you can see the ice ball on the ultrasound, and I believe on your website it says that it becomes very dark during the procedure. What about after the procedure, after the ice has melted and everything? Because the reason I'm asking this question is because, as we all know, during a thermal ablation with heat, everything changes that's been burned to a very dark color. So what about after a cryoablation? Is there something like that happens to the tissue, or how do you know after things have melted where you have treated and where you haven't?
Thank you for this very good question. This is because it is really interesting, and I have discovered it during my maybe 10th case that the color of the frozen area is changing after ablation. So normally we see the thyroid tissue gray to white, more white. And but the ice ball, as you said, is completely dark, and it is not possible to see the back part of the ice ball. So you can just estimate it. You can see the needle, you can see the front part, and you could estimate the back part. And interestingly, the frozen area looks in between, looks gray. Okay, not dark, but gray. So after the ice melts, you can see the frozen area with very clear boundaries, and you can see the cancer or the nodule in the center. you can see the safety area around the nodule very well.
Do you treat
So
outside the edges of the nodule?
Yes,
Okay.
yes.
Okay.
Yeah. So we generally, if it is cancer, for example, we prefer to freeze at least 5 millimeters beyond.
Okay. Okay. And then after, when this patient comes back for a follow-up, what do you see then?
We typically invite our patients for the follow-up about 6 months later.
Okay.
Okay. And at 6 months later, after cryoablation, we are surprised to see that in about half of the patients, the papillary cancer, the tumor, disappears.
Wow.
So it is not seen. The tissue looks normal, and the tissue undergoes some atrophy, the shrinkage. But in the middle of this shrunk area, we don't see anything. It looks like a normal tissue. So this happens in about half of the patients. And in the second half, for reasons unknown to me, we see remnants. But it is much smaller than I see after RFA or laser.
My goodness. Have you ever done a biopsy on that remnant to see what the cells are like after they've been frozen and died?
No, because I was practically sure that the biopsy will reveal only the dead cells.
Okay.
And some fibrosis. Instead, we prefer to keep the patients on follow-up. So if we see suspicious development, for example, a growth, or change in size or appearance, then of course we would do a biopsy. But I must tell you that this has not happened to me so far. Of course, we know that even after total removal of the thyroid, there may be some metastasis in the lymph nodes. So I think it's still too early to say this, to claim this. So we will sooner or later see some metastasis of the lymph nodes also. But the good thing is we can do these treatments to the lymph nodes also.
Really? My goodness. So how many lymph nodes would you treat at a time? Is there a limit?
Okay. Our policy for the thyroid lymph node metastasis is to wait initially, because in most patients, these lymph node metastases are very self-limiting. They don't grow for a long time, sometimes forever.
Right.
So we just follow them up, and if one or two lymph nodes grow, then we typically do ablation for these lymph nodes that has grown. So we leave the rest. We can repeat the procedures. Okay, these procedures are repeatable. This is
my next question.
Yeah, very repeatable. So you can repeat as many times as necessary.
Okay.
So I think this is something that is very underestimated or under-mentioned in the literature. Because for cancer, for example, the second surgery is, more difficult, and third surgery is much more difficult. And for radiotherapy, you wouldn't like to radiate the same area after the first radiotherapy. It is generally impossible. But with cryoablation and other ablations, you can repeat the procedure as necessary.
And it doesn't cause any scar tissue to develop in the neck that would cause any further treatment to be more difficult, is what I'm
okay, there is no scar tissue, there is no incision, or there is nothing on the skin.
Wow. This is so interesting. You started off telling us about thyroid arterial embolization at the very beginning. You were telling a story about how you tried that in a patient. Were you the first person to do this in the world?
Okay, first for the nodular goiters, for the thyroid nodes, and also large goiters.
Oh, wow.
I'm not the first to do thyroid embolization because it's been done before for disease. Okay, for Graves' disease, I also do thyroid embolization. It is, it's successful in about half of the patients in Graves' disease. So you need to select the cases carefully. But for the nodular goiter, it works very well because the shrinkage after embolization is much more marked ablations.
Yes, I just learned about embolization this year. I've heard of it, but I didn't really know the specifics of the procedure until earlier this year. I interviewed another physician in the US who's doing embolization, and embolization is not as widely known about. It's more known about in our community than cryoablation, but it seems like it's starting to kind of grow. In the United States, we're seeing a few more doctors that are offering it as a procedure. So I would love to talk with you more about, just to help grow awareness on how this procedure works, how you would do this procedure. I know that some doctors go through the wrist, some go through the groin, and then you embolize the arteries feeding into the thyroid. Can you tell us a little bit about that?
Thyroid embolization is an angiography procedure. We prefer groin more than the arm. Okay, because it is technically easier to put the catheter inside the four arteries of the feeding arteries of the thyroid. So we prefer groin. Actually, we rely on our past experience with neurointerventions. I have done a lot of neurointervention. I think it is a good advantage because we are familiar with the anatomy of this area.
Right.
So thyroid embolization is a little bit different from the fibroid embolization in the uterus, because uterus is in the lower abdomen, much safer area.
Okay.
But the thyroid is located very close to the cerebral arteries.
Right.
So you need to be familiar with the anatomy, and you need to be experienced in navigating in these vessels and doing procedures in that area. My colleagues who wish to start this procedure should be very attentive. This is a dangerous area. You must admit this. Care must be taken. We shouldn't harm the patient at all.
Exactly.
Okay? So I have some lectures in congresses, and this is the first thing I would like to emphasize, because this is a very good treatment, and we shouldn't kill this treatment before giving birth. Okay, we need to be very careful, not only for our patients, but for a very good treatment that is a good alternative to surgery.
It's most exciting, I think, for those patients, as you mentioned, with Graves' disease, who really don't have any alternative with, thyroid RFA, laser, microwave. Those will not work for Graves' disease. They would work for a toxic thyroid nodule, but they wouldn't work for Graves' disease. And so for thyroid patients with Graves' disease who don't want radiation, that's the only option that I've heard of they would be able to pursue. And then it's also so very exciting for those patients with the goiters going down into the chest. I recently interviewed 2 patients who had that experience and had just a rapid and massive reduction in their goiter. Avoidance of that sternotomy procedure during surgery is a big deal. I personally was kind of scared that I was going to have to go through that, because 20% of my thyroid nodule was actually below the collarbone. And I was pretty scared of the idea of that happening to me. So I'm happy for these patients that they have this as an option. One question that I would like to ask about thyroid arterial embolization is, when you perform this on someone with Graves' disease and it allows them to become normal thyroid, that's awesome. How does it not cause someone with normal thyroid function to become hypothyroid?
Because embolization is not as long-lasting as radioactive iodine, for example.
Okay.
Because when you receive radiation, it stays in the thyroid for a long time, and it continues to irradiate the tissue. So it generally kills the thyroid completely. So if you're receiving radioactive iodine, it is very likely that you will end up with hypothyroidism. And in embolization, you're not using radiation.
Right.
You're just occluding the vessels. And this occlusion is not permanent.
Okay.
So in several weeks or in 1 month, for example, if you do angiography, you will see that the vessels are open again.
Okay.
But during this closed period, a big part of the nodules and some of the thyroid tissue will undergo necrosis. But since the rest of the thyroid tissue that remain alive will be healthy, it has the ability to grow again. In our patient, if the patient is a thyroid, normal thyroid function, I have never seen a hypothyroidism afterwards. So this is the difference between the radioactive iodine and the embolization. But regarding the Graves' disease, okay, I don't routinely do embolization in any kind of Graves' disease. So I select the patients that I believe I will be most helpful. Okay, what kind of patients are better candidates for this procedure? For example, if you are young, getting a lot of radiation is not a good idea, because you will have a lot more years to live in France, and you are more likely to have problems in the future. And you wouldn't like to have subfertility. Yes. Because radiation may affect this. And you may have other problems in the salivary glands. So if the patient is young, my first choice is not radioactive iodine. And surgery is, to me, surgery does not make any sense, because you are exposing the patient to the risks of the surgery. This is one thing. And what you are trying to do, you are trying to save the patient from lifelong medications use. Right. Okay? But when you do surgery, the patient is starting carnimazole or thiramazole, but then starts to take level drugs. Right. So from another medication to another medication. Exactly. So it will not help. It will not help the patient. So I think in Graves' disease, surgery should be very exceptionally used. So the radioactive iodine may make sense if the patient is a little bit old, and if the thyroid gland is small, at least not big, because the bigger the thyroid gland, the radiation dose should be much higher. Oh, wow. So, yeah, because it is directly related to the volume of the thyroid. If the volume is high, then you need to inject more, or you need to give more radiation to have the same effect. Regarding all these things, I think I would treat young patients with large thyroids. These are the best candidates for embolization treatments in Graves' disease. And we must admit that in Graves' disease, none of these treatments are maybe permanent and not perfect. Because Graves' disease is, in Graves' disease, we are not treating the underlying cause. We are treating the target organ. Right. We are trying to treat or remove the target organ.
And I know that your focus is not on the immune system as a physician, but my understanding is that if you remove an autoimmune disease organ, then the body's just going to start attacking something else as part of the autoimmune process. So as you said, you're not addressing the root cause of the problem. You're just treating the symptoms. And you mentioned about fertility. This is so important. As a mom myself, 30% of Save Your Thyroid, which is 10,000 plus people, most of them are women. 30% of them are women in their fertility window. That's important to consider preservation of fertility, particularly, if women aren't in that age group aren't finished yet having children. Aside from other risks that come along with being exposed to radiations. I think that's so helpful. I would love to know about combining this procedure, embolization, with other ablations that you do. Is there ever an indication for that?
Yes. We have actually quite a lot of such patients, because For example, in multinodular goiter, our first choice is embolization because it will treat all the nodules in one go, in one single procedure. So you don't need to hit them one by one as in ablation. But after embolization, some of the nodules may remain still big or may not shrink enough. So for such nodules, we do ablation afterwards. It may be laser ablation or RF ablation or cryoablation. So we routinely do and we routinely offer such treatments. And I also have heard that in some patients that we embolized before, the patient got ablation in his or her own country by another doctors, which is a good choice.
When you do that, have you ever done that like within the same day or within a few days of this embolization procedure? Or is that something where the patient would have the embolization and then come back months later for the second procedure of an ablation?
Yeah. I mean, if the embolization procedure is successful, we just wait because we need to see the result.
Okay.
And in many patients, a second procedure will not be necessary. But if it becomes necessary, this is another weapon in our arsenal. So we can of course do this very easily.
And I forgot to mention or to ask this earlier when you were going through how the procedure is done. Is embolization something that you do on an outpatient basis, or is that in the hospital procedure where the patient is admitted and has to stay overnight?
Okay, we have done embolizations either in the hospital, but more recently in our own center, using the angiography units at our centers. So it is basically an outpatient procedure, but since the patient has to stay in bed for about 5 to 6 hours afterwards, we generally discharge the patients the next day. So the patient just stays overnight, and then the next day he or she is allowed to go to hotel or home. But we need to follow up the patients because after embolization, there is a specific condition called post-embolization hyperthyroidism.
Right.
So this happens because some of the thyroid tissue and also the nodules become dead, and more thyroid hormones will go into the blood circulation. So when you check the hormones of such patients, we frequently see that the T3 or T4 are high and TSH is very low. But interestingly, these patients have much less symptoms than we expect. I don't know the reason. We just ask the patient whether they have any complaints. So if they have complaints, we can give some medications like propranolol or some anti-thyroid drugs. But many patients pass this period uneventfully without any medication.
How long does that period last usually?
A couple of weeks.
Okay.
We just follow up these patients. We ask them to send us a blood test every week or every other week, depending on the level of the hormones. And for the last couple of years, we asked patients to use anti-thyroid medications 2 weeks before the procedure, because we saw that if they do this, post-embolization hyperthyroidism is much less severe.
I'd like to take a moment to thank the sponsor of this episode, Cambridge Interventional. Cambridge Interventional, a US-based company, has decades of experience in development, manufacturing, and sales of RFA and other medical devices. Radiofrequency ablation is a non-surgical, minimally invasive thermal ablation procedure used to treat various tumors, including thyroid nodules. If you have watched this channel before, you know that I personally underwent thyroid RFA treatment for a very large thyroid nodule and was able to save my thyroid and avoid surgery. If you'd like to learn more about Cambridge Interventional, please visit their website, cambridgeinterventional.com. A big thanks goes out to Cambridge Interventional for helping physicians to save thyroids and also for supporting this channel by sponsoring this episode. Now, back to the podcast. let's just kind of go back, since I asked about thyroid embolization. Is that inpatient or outpatient? What about all of the other procedures that you offer as far as thyroid ablation? Are those all outpatient procedures as well?
Yeah, I mean, all ablations are outpatient procedures. For laser, RF, or cryoablation, we typically keep the patient about 1 hour, and we'll let them go. If we use a laser or RF, we give them painkillers. If it is cryoablation, we don't need any painkillers because we know that it is painless, practically painless afterwards. But after cryoablation, there is more swelling.
Okay.
Compared to RFA and laser, and also more bruising.
Okay.
Okay. So we warn our patients about this possibility, but we don't typically prescribe any painkillers.
Interesting. Okay. I have a few questions from the community that patients wanted me to ask you. Okay, this patient wants to know, could embolization or cryoablation be beneficial for large thyroid nodules that have had 2 unsuccessful RFA procedures?
Yeah, definitely. Maybe I think I forgot to tell you that if the patient is not suitable for RFA because of the large size, and we offer cryoablation as a second choice, because there's a difference with RFA and cryoablation. In RFA, laser, or microwave, we are using the moving shot technique. So we are moving the needle continuously because we don't want to overheat the tissue, and we don't want to harm the surrounding tissues. So we are continuously moving it. But in theory, if you are moving the needle continuously, there is always possibility that some of the tissues are not killed. This is what happens in reality. So because if the nodule is benign, we don't have to kill it completely, because all we have to do is to make it smaller.
Right.
And this moving shot technique is sufficient for this purpose. Cryoablation is different. If you're using cryoablation, we put the needle and we don't move it.
Okay.
And there is no overlap. Okay, there is no untouched or untreated areas.
Okay.
So you are killing the whole tissue. Okay, if the tissue is too big, you can do overlap ablations. So you can freeze one tissue, you can remove the needle, put the needle aside, and you can enlarge every time the ablated area, and you will be able to see it with ultrasound. In conclusion, cryoablation kills more tissue than RFA and laser. It has the potential to kill the nodule completely. So this is the reason why we prefer it in large nodules, not very suitable for RFA, in hot nodules or active nodules, especially if the nodule is larger than 2.5 centimeter, because we know that if the nodule is big, a toxic nodule is big, generally RFA and laser are not very successful, or they are successful in about 50% of such cases. So if there is a large hot nodule, our first choice is cryoablation, not RFA. And cancers, and suspicious for cancers, because we need to kill that tissue completely.
Definitely.
And we are not able to do this with RFA because of this moving shot technique.
I suspect that partially answers the next question, which is, why does RFA not work for some nodules? Because we've had a very small number of patients in our community who've undergone 2 procedures of RFA, and their nodule either did not shrink at all or it grew back a little bit. Can you explain why this doesn't always work for these nodules?
Yeah, I think it is directly related to the aggressiveness and the experience of the operator. Because, ablations are not uniform. The more energy you give to the nodule, the more likely you have a greater effect, but the more likely you have complications.
Right.
So it is totally dependent on the experience and the aggressiveness of the operator. If the operator is a little bit aggressive, but also experienced, then he or she will be able to protect the tissue by giving some hydrodissection or other things. So he will be able to do a more aggressive ablation to the nodule. More aggressive ablation means more energy. So more energy means a better result. So I think this is the reason, because I know very well that in my friends, for example, my colleagues, some are telling that okay, they are very concerned about harming the patient. So they they do it in 5 minutes sometimes, and others do it in 20 minutes. So naturally, this will be a difference. Other things are that if the nodule is big, the percentage of shrinkage will be smaller.
Right. Yes. And we have seen some patients with really big nodules have really great reductions, and others will only get, 50%. And that's because there's more nodule there that has to shrink. And so your percentage is just not going to be as high. Next question is, what is the recovery process like for cryoablation and embolization?
Okay. Like any other ablations, we discharge the patient about 1 hour observation after cryoablation. But we warn the patient about the swelling, and more bruising.
Mm-hmm.
But we always follow up our patients. Most of our patients are overseas patients.
Yes.
So we use WhatsApp, we use other, communications, we use phone contact, and they send some pictures to us, etc. But in the end, in a couple of weeks, all this swelling and bruising will go away, and the patient will be very happy. In embolization, it takes a little bit longer because the post-embolization hyperthyroidism is more prominent after embolization. Mm. It may happen after ablation also. And it does happen if we cryoablate, for example, a large nodule.
Mm-hmm.
So if you are ablating a large nodule, we still prescribe the patient some anti-thyroid drugs before cryoablation also. Basically, the post-embolization period is quite comfortable after both procedures, but there may be some fluctuations in the hormonal level.
This patient wants to know, cryoablation can be used on a larger nodule that is in the isthmus and pressing against the trachea. This patient was told that RFA would not be able to ablate the entire nodule due to risk of damage at the trachea or the vocal cords.
Okay, isthmus is not very dangerous for the vocal cords paralysis because the nerve is a little bit down, but isthmus is just over the trachea. So heat-based ablations may be a little bit dangerous to the trachea. If you want to do this, you can still put a needle between the trachea and the thyroid and use hydrodissection. Okay. In cryoablation, this is generally not necessary because we know that ice will not have a significant harm in the trachea, in the collagenous tissues. This is also true for the thyroid cancers located in the isthmus. Mm-hmm. That has protruded outside the thyroid into the muscles. Many people think that this is a contraindication for ablation, but if you're using cryoablation in this area, and such nodules are very easy to treat because you will be able to see that the ice wall will become close to the skin, glued the muscles, mm-hmm. But after the procedure, you will see that the muscle is, there's nothing to the muscle.
I've seen on your website, you had some patients with very, very large nodules. In fact, when I interviewed your patient, Kathy, she had a huge goiter, and her reduction was just absolutely incredible. You had some of these case studies on your website of patients who, as she said, looked like they had two heads because they had just enormous goiters. What is the size of the largest goiter you've ever successfully treated?
She was one of the patients with very large goiters. I had in the past, I had larger goiters, but I don't remember the size. One of the patients underwent embolization 2 times, mm-hmm. But this was not our choice. He had a very large goiter, and it was evident from outside. Mm-hmm. And also it was growing inside into the chest cavity.
Wow.
And I had the MRI pictures of the patients before and after. Good thing is, Goiter also shrank from the bottom. Mm-hmm. So it was 8 centimeters down from the clavicle. And after embolization, a single embolization, it was 3 centimeters.
Wow.
But the patient insisted that I should do another embolization. Mm-hmm. I did not resist, actually. I didn't say no, because the original size of the thyroid was so big. So I thought another embolization would be better. And I did the embolization 1.5 years later, although there was no regrowth. And then the second embolization also caused further shrinkage. Mm-hmm. And interestingly, after these 2 embolizations, the hormones are still normal. After 4 years, he still has normal hormone levels. So this is something very good about thyroid embolization. This is unlike the other procedures like surgery and radioactive iodine.
That's so incredible. I think that you have really, as you said, been creative here. You've been able to use all of these different procedures and apply them in different ways and in combinations that always have the same final goal, which is to save that patient's thyroid. And I just think that's so marvelous. And so I applaud you, Dr. Yilmaz. Thank you so much for what you're doing and for helping patients like this. What is the best way for patients to contact you? Is that through your website, the contact form on your website?
Yeah, I think this is the most appropriate way. They can phone also our numbers. Okay. But even if they phone, we cannot tell them something concrete without seeing the results. So we need a thyroid ultrasound. If the patient has a very large or intrathoracic goiter, it's better we see the report of an MRI or CT, because ultrasound is not able to show this area, right, chest. This is the most important thing. And we need to see the hormone levels, because we need to see whether if the patient has hyperthyroidism, this is due to Graves' disease, or this is because just the thyroid is big. Because if it is just the large size of the thyroid, and after embolization, for example, we can almost definitely tell the patient that their hormones will return to normal. Mm-hmm. But if it is because of the Graves' disease, then this possibility is about 50%. Mm-hmm. So this is important. Mm-hmm. And finally, if there is a biopsy result, we need to see it before the patients come.
So the patient will have to send you all of their ultrasounds and their labs and their biopsy results. And do you ever do biopsies there in your clinic also, like right before doing a procedure to determine if that's a good course of action?
Yeah, we are quite lucky because in Turkey, everything is quite fast. In Antalya, for example, many people come, we just examine, we do the ultrasound, and we also do almost a whole body ultrasound, even if the patient comes just for the thyroid, mm-hmm, or just for the breast cancer, for example. We always try, because we know that in many countries, this is very difficult to reach. In many patients, they have a lot of difficulties in getting ultrasound, etc. As soon as the patient comes, we do a thyroid ultrasound. If the patient is female, a breast ultrasound, axillary ultrasound, abdominal ultrasound, to see the whole picture. Because in some patients, we see other things that may require treatments. And it is not very rare that in a patient, for example, we see a breast cancer and also a thyroid papillary cancer.
Oh, wow.
And since we are able to treat them both, mm-hmm, with the cryoablation, we can do both treatments in the same session. So we always do an overall ultrasound as the first evaluation. In Antalya, for example, in our Antalya center, the biopsy result will be available in Monday. Mm-hmm. So if you are doing a thyroid biopsy, then the result will be available next day. Mm-hmm. So in Istanbul, it takes a little bit longer, like 5 days or a week. Mm-hmm. So we routinely do a biopsy. But you know what? If the first biopsy result is inconclusive, for example, if the biopsy says there is atypia, or is suspicious for cancer, then in the past we always followed up these patients for years, and we did a lot of biopsies. I have seen that this is not a good way to go, because these patients suffer most, actually.
Yeah.
If the biopsy result is suspicious,
Yeah.
then they are forced to undergo surgery. But if they do surgery, in about 80% of the cases, this is just for nothing. They use thyroid and they don't have any cancer. They learn that they don't have any cancer. So this is something very bad. And if they stay on follow, then it makes a lot of stress, because you know that you may have a thyroid cancer, but nobody's telling you something certain.
Mm-hmm.
And even if the subsequent biopsy results are benign, you can never make sure that they are already actually benign.
Mm-hmm.
So both ways have a lot of defects, not perfect. So for the last 5 years, based on our good results with cryoablation on thyroid cancers, I started to treat such patients directly with cryoablation, because even if the nodule is cancer, we know that we are able to treat it. If it is not cancer, we know that cryoablation is also doing a benign nodule very well.
Mm-hmm.
So our policy is now quite simple. If the nodule is benign, our first choice is laser or RF or alcohol if it is a cystic nodule,
Mm-hmm.
because we know that they are cheap.
Right.
So we need to consider the cost also. If the patient has a suspicious nodule, now we don't do another virus. We do direct treatments, because we know that cryoablation is kill the nodule completely, whether it is benign or malignant. And if the nodule is malignant, in most of the time, if there is no biopsy-proven lymph-node metastasis, we do almost all thyroid cancers cryoablation treatments. And we are very happy about it. But if there are significant or, very visible lymph node metastasis, then we send such patients to surgery.
Right. Even what you were mentioning about the nodules that are not 100% confirmed benign or cancerous, that is an area that we've seen, as you were saying, those patients are they're conflicted about, should I go have surgery? Because as you said, so many of them end up being benign on their post-surgical pathology. And to me, that's just tragic, because it's like, well, you just went through a wasted surgery and lost your thyroid, and now you have to be on medication for the rest of your life. So having something like this available for those patients, that's tremendous. So I'm very excited about this, Dr. Yilmaz. I'm so glad you shared this with me today.
I just would like to thank you for this, for providing this opportunity for me. It was very nice to meet you and talk to you, answer your questions. I hope it will be beneficial for our patients.
Absolutely.
So they may consult us anytime. They just need to send ultrasound results, thyroid hormone results, and biopsy results, and we will definitely give an answer sooner or later. Okay, we are very busy normally, but me, our secretaries, and the other doctors also working in our clinic are very enthusiastic about contacting patients. So we are very happy that we are being helpful to our patients. So thank you again for this nice talk. And
it's been a pleasure.
You.
I have absolutely learned so much today. Thank you for your time, and thank you for how you're helping other patients in this world to save their thyroids. Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle, It's Me, Jenna. Never forget to educate yourself and be your own advocate and save your thyroid.